My name's Heather Hart. I'm a clinical dietitian at Northwell, Long Island Jewish Valley Stream. Today, your professor, Professor Feldman, had asked me to speak about my experience during the COVID-19 pandemic. And undoubtedly, I said, of course I would, because I, not too long ago, was in your seats. I'm a graduate from Long Island University post-campus. Later, I got my master's at Stony Brook University. And I started working at Northwell, which your professor was my boss, about a year and 7 months ago. So the first question she asked was, how has your role changed since COVID-19? From the beginning of the crisis or the pandemic to now, a lot of things have changed naturally. As you can imagine, there's a lot more high-risk exposures and precautions that need to be taken. And it was very high, especially for here in New York. So we had to find ways to obtain the proper nutrition for these patients without exposing ourselves or limiting contact as much as possible. This also saved vital PPE for the nursing staff and doctors that need it for emergency procedures and rounding on the patients and making sure they're getting the essential care that keeps them alive. Not to say that our nutrition isn't important, and so I'll go into that too. So she wanted me to say, how does it feel to be on the front line? So it's a little nerve-wracking at times. We do go to the floors and we talk to the nurses. There are moments where it becomes a little much because it's overwhelming, especially in the beginning. There was an influx of patients. During the peak, we definitely felt the stress of that. There were patients coming into the ER. At one time, I believe there was 150 patients. We had to transform a few units into an ER. And we've made units that were originally for outpatient, like ambulatory surgeries, that people would stay there very shortly. Those became ICU, CCU units. Our surgical units became ICU, CCU units. And, we went from there. So that definitely made it a little more nerve-wracking going into work. This is definitely not for the weak-hearted. This test, why you get in it. So it's funny because Professor Feldman told me when I first got hired, she's like, this isn't going to be like high-end critical care. We're not going to get the helicopter people with gunshot wounds and stuff like that. They go to different hospitals because we don't take that much of critical cases. But given the current circumstances, we started receiving some pretty critical patients, or patients came in fine and their condition escalated quickly. So we had to navigate through that in a nutrition standpoint among us as a team. So how has our role changed is that, I'm going to go back to that one. We aren't seeing these patients, so that is a big component of what we do, especially when we want to diagnose with malnutrition. And also you can get a sense for the person's state, and you could see if they're malnourished, dehydrated, or you can find out a lot of information that you can't find out on the chart. So what we do is if the patient can talk, we speak to the patient over the phone. We also go in, like I said, to the floors. We talk to the nurses, we talk to doctors, we call family, and we obtain all the information. So if I've been asked before, do you feel like your ability to help patients' nutritional status has been hindered? I say no, it just takes a little longer. We become a bit of a detective and start to try to find out what these patients' needs are. What conditions do they have? Are there underlying conditions that weren't necessarily known by the patient, but we see through the labs? Or maybe they do have it, but they came in such a state. Maybe they came, they weren't able to talk, not alert and oriented. So we have to obtain that maybe by calling the family members, and we're the first to find out something. And we know that we have to find either different formulas or different diets for these patients. So the next thing she asked was, how does nutrition impact COVID patients? Intubations, eating, are they able to eat, tube feedings? So that's very big. So this, like I said, has changed our scope of practice a lot. We are more of a critical care team now because of the status these patients are in. This has been challenging, but it's been doable, and as the hospital as a whole has been coming together and really been allowing us to be a part of the team. So it's exciting. It's exciting given a not so good situation. We are able to start these tube feedings early for people that are not doing well, and for the people that are intubated, they are assessed via the nurses. So we speak to the nurses. We ask, is this patient eating? Do you think are they choking when they're swallowing anything? Do you think maybe they want something soft, or maybe we should do something pureed, or maybe we give them a nutritional supplement, maybe something easy for them. We'll find out food preferences from family members to encourage them to eat so they don't become malnourished, because as you guys should know by now, nutrition is a very important component of a patient's outcome in the hospital. Once they're intubated, it's a lot different than some other intubations in a sense that this is a virus that attacks the lungs, and it causes something called ARDS, which is acute respiratory distress syndrome, a big buildup of fluid in the lungs causing them to desaturate, so they're not able to take in the oxygen that they need. So patients are being intubated at an alarming rate, and it's happening quickly to a lot of people of all ages. And so that is the first line of care. The second line of care is making sure that the patient's hemodynamically stable. So we want to make sure that they're hydrated, they're getting the meds, their pressors, and all these doctor terms, but they make sure that they're stable. The last little component that we try to put in there, which statistics show within 24 to 48 hours, is starting some type of nutritional tube feeding. Enteral feeding is vital for the patient outcome. So we have been working with the doctors because they have started some tube feedings, but doctors, it's not really their specialty. They are doing awesome things with medications and everything else. So we ask them to put in a tube feeding. This is how we do it. Since we're not allowed to go talk to the patients, we're not really going to the floors in these floors because we consider them actual COVID units, because it's that high risk and high transmission that you have to be completely gowned up, and we're trying to save the PPE for them. So we contact them on the phone. So we ask them to put in a low tube feeding, like a trickle feeding, and they'll put in just some generic whatever. And most nurses will start it, and it's typically a formula that is not going to hurt them, and it's at a rate that wouldn't hurt the person. So then we go and assess within 48 hours. We'll assess the nutritional needs of these patients. We'll see if they have any underlying issues. A lot of them, because of the condition, they are going in acute kidney failure. They're a lot of their labs are really out of whack. So we'll see some Suplena, and if they need to get dialysis, then we change it over to Nepro. I'm not sure if you guys are familiar with all these formulas, but we pretty much have to adjust things pretty quickly because the status is constantly changing with these patients. And that requires us to follow up on them more frequently, and making sure that the nurses are getting their orders. The other limitation is pumps. So typically in a normal functioning hospital, we have these pumps that feed the enteral nutrition. So that's like tube feedings. Those are limited right now. So now we're relying on some bolus feeding, and nurses they're trained to do it, but as you can imagine, they're very overwhelmed, and they have to stand there and make sure that these patients are being fed with a bolus, which is one bulk of fluid going in all at one time. So we calculate the needs doing that, and we are communicating with the nursing staff, and they're making sure they're doing it, and it's putting a little bit of strain, but the outcome's becoming better. So we are getting proper nutrition to these patients. And this helps ensure that their lungs and everything their whole body recovers. So are you guys making any other specific recommendations? So the guidelines have changed because of the, we usually go by the Aspen guidelines, but we have been staying abreast on all the latest research and the recommendations for specifically the COVID patients. And we have to adjust our tube feeding. So like I said, Saplena is something for patients that are in kidney failure, but they're not on dialysis yet. These patients never had kidney issues before they came in, but because of their chemistry, their biochemistry right now, it's making us like we have no choice but to put Saplena or Nepro, and these people are in ICU. Usually we do Vital for some of these cases. And now the new recommendations are saying that we need to use regular formulas with fiber. So we are making the adjustments accordingly, and we're making the recommendations accordingly. Doctors are being great and they're listening to us. They definitely need us, and they feel like, where are you? We need this tube feed now. And so we're there, and we feel part of the team, and great. We're more than happy to help out. So the last thing your professor asked, was any thoughts about how COVID-19 affects food insecurity? So unfortunately in the hospital, a lot of we have a program called Food is Health. It's an amazing program that allows patients that are food insecure to take like a bag of food home with fresh produce and very healthy things that are within their prescribed diet. So that is great, but unfortunately during this time that's kind of been put on a standstill just because of contact precautions for the people delivering the food. So from the hospital perspective, unfortunately we aren't doing what we used to do, but we still have our social workers and case managers helping those that are unable to provide food for themselves through SNAP and other community benefits or community pantries and things like that. Personally, I think food insecurity from just a personal standpoint it's a real thing, and it's really starting to affect more and more people, especially the what we call the working poor, those who live paycheck to paycheck, and right now they're not getting that paycheck, and with unemployment checks not coming in, you're seeing a lot of the pantries being exhausted, and these people that are running the pantries are starting to get sick. So it's definitely something that I hold close to my heart, and unfortunately this COVID-19 is definitely affecting everyone. And so that's just my thoughts on it. What I can do is I try to help. I ask people if they need help with anything, but that's the most that we can do. And obviously if I see a patient or hear a patient feeling that they're insecure, or I'm talking to a family member, I bring that attention to the social worker to see if they can help in any way. So those are the questions that she asked me to answer, and I hope you guys got something out of it. There's so much more that I could talk about, but overall this is it's a life-changing experience that I don't think we'll ever see anything like this in our lifetime, and at least I pray that we don't. And I'm happy that you guys are choosing the field of nutrition. Continue to do this, and if you guys ever get the opportunity to educate or speak to anybody moving forward and later on in your careers, I strongly encourage you to do